Welcome back to the COVID updates from Wild Health. The following podcast is one that was recorded by myself, Dr. Mike Stone, Dr. Jacob Avila, and Dr. Michael Prats. The three gentlemen with me on this podcast are nationally renowned experts in point-of-care ultrasound. Point-of-care ultrasound is basically the use of ultrasound by providers at the bedside, not by radiologists. And we talk in this podcast specifically about the use of ultrasound for the diagnosis of COVID. A lot of the things that we talk about are going to be slightly above the head of the average listener, but I do think it's interesting to understand how medicine is attempting to employ additional devices or things that weren't traditionally thought of as mainstream in what we're currently dealing with this national crisis. So please feel free to listen. If you're not interested in how we could be using point-of-care ultrasound either remotely or in the diagnosis or treatment of COVID, then skip on to the next podcast.
So there's a lot of potential applications for this, and I think the best way to use it is however is best where you are working. Ultrasound should be a arrow in your toolbox or a tool in your quiver. So you basically have to use it the way that it's best to be used. You can't just say that this is the way you're going to use it in all situations, if that makes sense. Do you guys agree with that?
None of that toolbox arrow stuff made any sense to me, so I'm confused.
Can we
now.
edit that out and then make it the beginning of the podcast now? Can that be like the intro music?
That's the lead-in for sure.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
This week, we tackle a very important topic, COVID-19. Now, this thing went from not a thing to 4 months later at the time of this recording. 4 months later, it's just everywhere. Now, we are getting some information about it as far as testing, CT scan characteristics, and we're starting to get more ultrasound findings that are being reported. In this podcast, Mike Prats, Mike Mallin, and Mike Stone from the Ultrasound Gel, Ultrasound Podcast, and Ultrasound Leadership Academy, respectively, we all got together and discussed our thoughts on COVID-19 and ultrasound. Check it out. Mike Mallin and Jacob Avila from the Ultrasound Podcast. We have Mike Stone from ULA and Michael Prats from the Ultrasound Gel Podcast and website. Guys, I'm feeling a little bit outnumbered here with all the mics that are going on right now. It's a lot. It's a lot of mics.
We've actually decided to refer to you as Mike for the remainder of the podcast, so to make things less confusing.
Great. My mom's going to be super confused because my brother's name is Mike. It's going to be great.
Your middle name's Mike, though.
Okay. Yeah, it's not, but that's
right.
fine.
As
It is today. Today
As
it
of
is.
right now.
It is. Guys, what are we doing here? What are all of us Mikes doing here today?
Well, Mike, we're here today. I don't know if you've heard about the COVID-19 global pandemic that's infecting the entire world. You might have heard of this. We decided, I think, sort of all independently, and then amongst communicating with one another, realized that we needed to get together and talk about this because there's clearly a role for ultrasound, and we need to talk about that because we're the Ultrasound Gel Podcast and the Ultrasound Leadership Academy and the Ultrasound Podcast, and obviously we got to talk about that. I'm really curious, though, have you guys heard of any firsthand accounts of people who are actually using ultrasound for COVID yet?
Yeah, that's the exciting part. I mean, it seems that people all over the world are actually using point-of-care ultrasound, specifically lung ultrasound, to take a look at these COVID patients, kind of following them in the ICUs, even in the emergency departments, and it seems really exciting for people who like to use ultrasound.
Yeah, there's a bunch of folks using lung ultrasound, ranging from, intensivists and ER docs. Largely, most of the experience that I've heard has been from Italy and from China, where doing CT is somewhat impractical with the long clean times and the transport of the patients back and forth, and then chest X-ray doesn't really perform that well for pneumonia and can lag in clinical findings. So Yeah, and then you've got this this ER doc in Spain, Jale, who's scanning himself with lung ultrasound and following the course of his own COVID-19 from quarantine. So we're seeing lots of stuff happening around lung ultrasound in this pandemic.
Yeah, agreed. It's kind of crazy to follow these people on Twitter, because not only are they posting pictures of their patients and what it looks like to help disseminate knowledge to help us try and find it earlier, but we're having like firsthand accounts, physicians that actually have personal, like literally personal experience with this. We're actually hopefully planning on interviewing one of the physicians who has been kind of teaching us on Twitter in a couple of days in part 2 of this podcast. Now, one of the things that I always like talk about is with ultrasound. I obviously love it, but we have other ways of diagnosing this, right? I mean, do we need ultrasound, or is this kind of like a thing that we're doing for fun? There's got to be another way to diagnose this.
Yeah, I think that's a really good point, and that hopefully we'll be able to tackle that through some discussion here. I mean, certainly there are more definitive ways to diagnose it at this point. I mean, there's a PCR test. There's a lot of different tests that have gone through various iterations as this is developed in the different parts of the world, and some people are developing their own kits. It seems that some of the tests are not that sensitive, especially early on in the course of the disease. And some I've heard reported positive rates as low as 30 to 60%. So it sounds extreme, but some people are even saying you need to do CT as a screening test for COVID. I know that will probably make a lot of people really worried about all the decontamination and cleaning that will have to occur after that, and transporting the patients. And there is a lot of problems if we're going to use CT as a screening method for these patients. So I think that's why some people have turned to ultrasound as a possibility.
Yeah, I mean, identifying these patients early on is huge, because even just the amount of personal protective equipment and personnel and resources that go into evaluating patients when they're not yet proven to be positive or negative for COVID, they're all treated as if they're positive. So the idea of taking these patients from an emergency department triage tent and moving them directly through a CT scanner at a busy hospital that manages trauma and stroke and everything else that we use CT scanners for pretty regularly, it's super impractical. And there are some pretty cool, as of yet non-validated triage algorithms that incorporate lung ultrasound, where you're looking at sort of a combination of oxygen saturation and lung ultrasound findings as a way to identify high-risk patients, and those could be the patients that you kind of bump up for an earlier advanced imaging study if they need it.
Yeah, I assume, Jacob, you plan on telling us more about the whole CT scan thing. I don't think I need to continue to talk about why that's a crazy idea. But one other point that I think hasn't been made yet is that we need to be able to diagnose these people outside of the hospital system. So they need to be able to be diagnosed in clinics, as Mike was mentioning, in tents. And a lot of them don't need to be admitted, and they need to go home and self-isolate. So we're looking for tools that we can use to diagnose patients without having to send them to a CT scanner, obviously, because that's just ridiculous. I mean, in my hospital, it would take at least 2 hours to clean up the CT scanner after sending a COVID patient over there. And I mean, there's no way you can shut down a CT scanner for 2 hours right now. It's just impossible.
So, Mike, if I understand you correctly, you're proposing that we move CT scanners out into these tents, as many as possible?
Outside, yep.
Yeah,
that's
into
right.
cars.
Or
Let's
into,
put them into cars.
The other thing you could do is you could
extension
just put
cords, surge protectors. Yeah.
Mm-hmm. Yep.
I think as long
Preferably-
as you don't put
preferably in
like
a
a hair
cafeteria.
dryer on it, it's okay. You just can't run the hair dryer and the CT scanner at the same time, but otherwise.
Yeah, because then
don't
you have
take
to
a
reset the
bath with
breaker.
it.
Yeah, you have to reset the breaker, and we don't want that.
Yikes.
Now,
Wow.
what I kind of like about this conversation is it's kind of in jest, but there's a reasoning behind it. I mean, most of the time when we talk about CT scans and how we want to use ultrasound instead of CT scans, we're talking about like radiation and stuff like that and time in the ED. But there's such a large quantity of these patients that, practically speaking, we will be unable to get all of the patients that might need to get some kind of a test through the CT scanner, clean the CT scanner, and get ready for the next patient. And then we all work in busy emergency departments. What happens when you have somebody that has a stroke or somebody that has, concern for a PE or something like that you really need the CT scanner for another thing? I mean, it's a lot more than just the radiation, which I think we're kind of alluding to. Now let's talk about this. Let's talk about the CT scanner. It's actually like a pretty good test for diagnosing it if we just look at just the data, forgetting that it's like this crazy pandemic. Now, we are still learning. This is still very early. I mean, the first time that this was described was in like December of 2019, which is really not that long away from when we're recording this, which is mid-March 2020. We do have some data, though. There's a study that's entitled Radiology Perspective of Coronavirus Disease 2019, Lessons from Severe Acute Respiratory Syndrome and Middle East Respiratory Syndrome, so SARS and MERS. It was published in the American Journal of, I don't know how to say this, Rentinology. I think they mean x-rays. I don't know. Rentinology in October of 2020. Now, what's really cool about this study is two things. So the first thing is that it's free and open access. So if you just Google this title that I just said, you're going to be able to download like the PDF for free, which is great.
It's never a good sign when the first thing that you can say is cool about a study is that it's free access.
I know, right? I mean, that's like messed up. But like usually, it takes like months for you to be able to like find an article, right? So
Fair.
Though I'm excited about this because this is like data dissemination. It's great. The second thing is, this virus actually is related to the MERS outbreak and SARS. So they're all kind of like interrelated. They're similar species of viruses, I guess. And if you download that article and look at it, they have a really good chart that actually walks you through the CT findings. Now, I'm not going to go through SARS. I'm not going to go through MERS, although they definitely have a chart that explains and that kind of compares and contrasts it. I just want to tell you what the typical, based off of this preliminary data, CT scan findings of COVID-19 are. And they are bilateral multifocal basal airspace disease with normal chest x-ray findings. They have peripheral multifocal airspace opacities, which they call GGOs, and those are sometimes seen on chest x-ray or CT, sometimes. So what is interesting about this that I think is really good for ultrasound is that it's peripheral, right? So it's found on the periphery of the lung, which is what ultrasound actually does great at.
Excellent. So we've got to be at least 15 minutes into the podcast, and you still haven't told me how to use ultrasound for COVID-19. Can somebody tell me how to use ultrasound for COVID-19 now?
Well, it starts with looking at the lungs. So it's
Nice.
interesting.
Yeah, good. Great. Thank you.
Most of the findings described have been in the lungs so far. And the cool thing, what I thought about this, so clearly you're not going to be able to see the lesions in the lungs if they're not close to the periphery. Because, if you hit that layer of air, you're not going to be able to see much behind it. Now, fortunately, one thing I read in some of these articles is that COVID-19 actually begins in the terminal alveoli. So a lot of the lesions are actually close to the pleura, which is ideal for ultrasound. And to start with, to kind of answer your question, Mike, like the findings of COVID-19 seem to be what we'd expect for a viral illness that can then go into a pneumonia. These are lung findings that we've seen in other diseases before. So let's take like bronchiolitis, where you might get some pleural line abnormalities, some subpleural consolidations, where you see that little, maybe a raggedy pleural line, and then maybe a little notch out from it from a consolidation that's forming there. And sometimes these are in more than one spot. Maybe they're all over the place. Maybe there's just a few of them. And we know that subpleural consolidations can be a couple different things, but for these viral illnesses, it seems like they're usually on the small side, so less than 0.5 centimeter. They may be bilateral, maybe one or two different spots. We've seen this in influenza. We've seen this in measles. There's been a couple different reports published about all these ultrasound findings of viral lung findings.
Is there any way to specifically diagnose COVID? So, like, I guess in that CT study that you were quoting, Jacob, they basically come up with a sensitivity that's extremely high because they're in an endemic area. Basically, is my interpretation of it. Is there anything specific to this virus that we can expect to see on ultrasound, differentiating it from other viral pneumonias? I guess
Not so much, and not yet. Maybe in the future we'll be able to actually figure this out once we get a lot more data. But for now, the main things are, the kind of patchy B lines, irregular pleural line, scattered consolidations, and no big significant pleural effusions. Those are kind of like the big things that are present in all viral pneumonias, but there's really no thing that says this is H1N1, this is measles, this is bronchiolitis, and this is COVID. It's really based off of your clinical suspicion, which I think is fair because you have somebody, let's say you diagnose a pneumonia, a bacterial pneumonia, with your ultrasound. There's no finding to say like, well, that's definitely strep, or that's definitely staph, or that's definitely, fungal pneumonia. So I think it's okay to be able to say it's a viral pneumonia, and then you think about the history of the physical exam, what's going on in your environment, and then kind of diagnose it based off of that, or at least preliminarily diagnose it based off of that.
One thing that I have heard is that there's been a decent amount of cardiomyopathy associated with this as well. Do you have any tips for differentiating basically viral pneumonia from B lines from heart failure?
Well, the way that I look at this is basically looking at the other stuff besides B lines. So in cardiogenic pulmonary edema and in viral pneumonia, you're going to have B lines. They're going to be present in both. Now with cardiogenic pulmonary edema, typically that's going to be relatively homogeneous. It'll start at the basis and kind of creep up. So you kind of see it everywhere. The pleural line is going to be nice and crisp. With a viral pneumonia, you will have patchy B lines. So you have areas of the lung that have a lot of B lines and areas of the lungs that don't really have that many B lines. You'll have an irregular pleural line. This is with viral pneumonia. And you'll also have small to maybe even medium-sized actual consolidations of the lung with it. Additionally, with cardiogenic pulmonary edema, you often see pleural effusions, whereas with viral pneumonias, you don't really see a whole lot of pleural effusions. So there's ways to tell the difference between viral pneumonia versus cardiogenic pulmonary edema, but not, like bronchiolitis versus COVID, for instance.
Gotcha.
And I think taking a look at the pleural line is what's going to be key there, because if some of these papers that we're going to talk about in a second, they all seem to have a lot of reports of these pleural abnormalities, whether it be some thickening or some notching or just kind of that jagged appearance of it.
Yeah, the other thing I'd just add is that the cardiomyopathy that we're hearing reports of, definitely not a standard thing that happens in the course of your run-of-the-mill COVID-19 infection, if we can presume to know what a run-of-the-mill one is. But even the sicker patients, they're coming in, they're having lung findings, and they're having preserved ejection fractions, and their hearts look fine. And then, somewhere 5-10 days into illness, they're developing, as their lung findings are improving, some of them then go on to have some what is presumed viral cardiomyopathy, although not really elucidated yet. But I think for the take home for me, and the pleural looks different in the same way that, like, if you're looking at an EKG, atrial fibrillation looks different than supraventricular tachycardia, right? I mean, like, things just, they look different. The pleural line in viral pneumonia looks different than one from just pulmonary edema. But because it's non-specific in the sense that, like, you could have some of those same findings with influenza, although typically in adults, my experience has been that I don't see a lot of these findings in influenza, that I may see a couple of scattered B lines, but not a whole lot of skip lesions or subpleural consolidations in influenza patients. But from a triage standpoint, not really diagnosis standpoint, I think there's potentially a huge role for ultrasound here, because the difference between a patient with a fever and an oxygen saturation of 95 who's got a bunch of subpleural consolidations and scattered B lines and thickened pleura versus clear lungs. Clear lungs is somebody who goes home, and you can wait for that COVID test to come back. You can self-isolate. Somebody who's saturating okay and doesn't have an oxygen requirement but has a lot of lung findings, that person needs to be monitored, not necessarily in hospital, but with a higher level of repeat imaging and anticipatory guidance and just like a different level of alertness.
I mean, I think the devil's in the details here, Mike, and I think you're kind of getting to it. It's that the diagnosis of COVID with ultrasound. the COVID findings in ultrasound, I think are useful, but it's going to be a very particular sort of situation where they're going to be useful. But I do think they're very useful. I think there's a way to apply it. The main clinical question I have is, how do we use it along with fever? How do we use it along with, an endemic area and a suspicion for illness and a pretest probability? Those are the real questions that I have. And I'm really interested to hear about these articles that Prats has got, Beard Mike has got for us. So I want to know what all they've looked at so far, and have they gone into that at all, or are they just describing the findings, I guess is my question.
Yeah, that's a really good question. So far, all that we have is really 40 patients total, and this comes from 2 different articles. So at first I thought it must be the same population because they are both just 20 patients, but totally different geographic parts of China. So the first study, I'll just mention them kind of briefly and go over some of the findings. First one came out February 26th, and this was 20 patients with diagnosed COVID-19 and pneumonia. And they looked at 12 lung zones, and their main findings were that B lines, discontinuous or fused B lines, were in about 40% of their patients. They saw some pleural line abnormalities in about 15%, those subpleural consolidations in a little over 20%, and then a smattering of some of the other findings like air bronchograms, localized pleural effusions, pleural thickenings. They actually did an interesting thing of looking at blood flow in these subpleural lesions and found out that they don't have very good Doppler signal there. The next paper came
does that
out
mean
in March.
necrosis?
Yeah, it's a little bit hard to interpret because, subpleural consolidations, my understanding is that it can be a lot of different things. We see those in pulmonary embolism, we see malignancies. So my thought was it's just trying to differentiate it from some of the other etiologies which might have a higher blood flow to the periphery. But I honestly was not exactly sure why they felt the need to test that in everyone with those.
I don't know what etiologies have a higher blood flow in the periphery. Do you guys?
I guess a cancer would. Yeah, a cancer would. And then technically a pneumonia, as far as I know, a bacterial pneumonia, if it's super consolidated, you should be able to see a decent amount of blood flow, I would think, because it's just you're seeing lung tissue now.
But they said a decreased blood flow, not absent blood flow, right?
That's why I'm confused, and that's why I'm wondering if it's necrotic, Precisely for that, because it's weird. It just doesn't add up to what I knew. But this is 20 patients also.
Exactly. Yeah. And honestly, the second paper, which was the March 12th paper that came out, it didn't really describe as many findings. It was a pretty brief paper. Both of these are really quick reads, and you should check them out. But similar findings of thickened pleural lines, irregular pleural lines, B lines, consolidations, and they noted that actually you can use the lung ultrasound to follow a patient's recovery because they said that those B lines disappeared, replaced by A lines once they started to improve. So I liked how the second paper mentioned early on in the infections, there's some more focal B lines, then it progressed to some more alveolar interstitial syndrome, and then as it resolved, went more towards A lines. So altogether, these papers are pretty consistent with showing some of these findings, and long story short, it can present like any other respiratory infection in a bunch of different ways. So it might be pleural irregularities, might be consolidations, and it might be B lines. The important thing I think is that, especially in the first paper where they detailed how they did these scans, they used both the linear and the curvilinear probes, which makes sense because if you're looking for these somewhat subtle pleural abnormalities, you're going to want that high frequency linear. But if you're going to be doing 12 lung zones and trying to cover a good amount of area for their bilateral lung fields, you probably want the curvilinear.
Any of you guys ever use Doppler in your lung ultrasound assessments?
No, not at all. I did it once because I saw somewhere about using Doppler for lung sliding, and I used it once, and I was like, I'm not sure this is necessary, but that's the only time I've ever done it. Power slide, yeah, the power slide.
I've done that. I mean, if you're using power slide to look for some lung sliding, you're kind of digging deep. There's probably just not lung sliding there.
Right. That's a good call.
All right, so preliminary data suggesting that I guess we're going to see similar findings to other viral pneumonias in these COVID patients. They're going to be more prominent in the posterior lung fields, more prominent inferiorly, it sounds like, likely bilateral, right? So a lot of the similar findings that we found with the CT study that came out of China as well. So I guess the first thing I'm thinking is, okay, maybe I can use ultrasound in the place of CT if I'm looking for additional diagnostic information for my patients and trying to determine if they've got a pulmonary infection associated with their viral infection. But the real question for me is still out there, and that's something that I think I'm going to get from you guys, not from the literature. And that's how do I use this in my daily practice right now? I don't know that I use it that much right now, but I can see how in 2 weeks I might be using it like all the time, every time. You know what I mean? What I'm getting at is the system isn't overrun right now. I've still got easy access to X-ray. I could reasonably get a CT on a patient who's, having, pulmonary decline. But those things may very well change very soon. And there also might be so many patients in front of me. I mean, there kind of already is so many patients that we don't have enough testing. So do we need to look to other areas for testing? Like the idea that Stone was talking about, sort of a decision tool where you've got, a fever and an elevated CRP and leukopenia and findings on, pulmonary ultrasound, boom, 90% sensitivity for COVID. I made that up, by the way. That's not actually a number, but I'm just thinking like how are we going to apply this? How are we going to use this and make it practical in our daily lives?
Yeah, and I think it comes down to whether you're going to use the ultrasound for the diagnosis up front or more so just to monitor the progression of the disease. So I kind of see it right now, and based on what we've seen so far, that it would be really useful for those patients that are like in the ICU or have been hospitalized with pretty severe disease and just kind of seeing what's going on with their lungs if they're not getting better. And maybe potentially in the future extending that to like upfront diagnosis in combination with some sort of like risk stratification.
Yeah, I agree with everything you guys are saying. I think there's, to me, I think the most promise is going to be in triage. I think ultimately we're looking at, 150,000 cases or 160,000 cases as of today, but we were 500 cases last week in the United States, and now it's 3,000 cases, and some of that's related to the availability of testing. But ultimately, if we really start looking at an additional several hundred patients a week coming to either screening tents or urgent care centers or emergency departments or doctors' offices, the ability to sort out whose lungs look okay. As of right now, that's the only real test we're going to get back beyond vital signs at scale is what do their lungs look like, and the only way we're going to get that is with ultrasound. So I think that's we don't know the answer to sort of what's the combination of a white blood cell count plus an LDH plus a lymphocyte count and an ultrasound score. I mean,
LDH, can you still get those, Mike?
You can, and you
should.
Our infectious disease folks actually like that for some early signs for improving your probability for COVID. But ultimately, right now, all of these PCR tests are a couple of day turnaround. And somebody comes to you with a cough and a fever, you don't know that answer. You can decide, you look clinically well, but we know that a lot of these cases accelerate really quickly, and they look pretty well at first. And I think the difference between seeing someone with no pulmonary involvement versus a bunch of pulmonary involvement, although they're young or, they're not that sick yet, I would want to either, whether you could leverage some telemedicine capabilities or whether you could have that person just come back for another scan. I think you could keep more people at home in isolation and save some resources in hospital for people who really need them, because we know we're going to run low on all of those. And that's where I see the most role. I mean, I do think you could follow along in the ICU, and our colleagues up north in Washington have been saying that they're noticing that they're going into the ICU rooms much less frequently, because it's not like you can forget something and then go right back out and change. The process of donning and doffing and just the equipment usage is so high that if you were able to ultrasound someone as opposed to moving them in and out for CT, I think that's going to provide value, or X-ray. I think that's going to provide value there too. So I think we're going to see that lung ultrasound as a role across the whole spectrum. But I do agree, I don't think it's going to help you with sort of, here's a patient with some junky lung sounds and they have a fever, and you look and they've, is it pneumonia, bacterial pneumonia? Is it COVID? Is it influenza? I don't think it's going to have that kind of diagnostic accuracy to kind of give you the clinch diagnosis at the bedside.
Well, I agree with you guys. I guess the extra thing is that I could imagine we have like we call it a pit shift, so physician and triage system, where we have one physician that's in charge of 2 rooms, and we just go like C1, scribe does the note, the nurses put in the orders, and then the APPs do kind of like the results. Go into one room, spend 5 minutes in a room, go to another room, and back and forth, so that a waiting room just like stays empty. And I could imagine being in a situation where we have an area of that with just patients with respiratory complaints. And what I imagine this would be useful for is in that situation, for me, it would be in that situation where I have a patient with respiratory complaints, I could get my history, do my physical exam, and then do a quick scan